So in this model, we have got 4 different segments. So, and I'll explain each one of these segments. The first segment is very easy. It works either with magnets, or you have for if you want to use navigation. You've got these 2 pins that you can kind of really tighten the orbit with. You've got a small plate, so it's easy to put on the desk and to explain. You've got this revolving knot that you can put in any different kind of a direction to simulate your surgery. So, so you can. This is according to DICOM images of a real person with really big, wide frontal and sphenoid sinuses, and this is what you need for transorbital surgery. You need big sinuses to get through the roof of the eye. You need to get to the frontal sinus, or you need to go through the lateral wall to get to the temporal fossa. So this model makes it really easy to understand the concept, and because people can see through the lining, you can see my finger here, how thin that bone is, and this is real life kind of situation where this bone is almost transparent, and you can often see the dura or the lining of the brain through there, and this would give you access to the whole anterior cranial fossa. Then you have your lateral wall of the eye, and you have your inferior wall. The medial wall of the eye is still within the main model. So this is really easy to explain to people: the superior orbital fissure, the inferior orbital fissure, and where the optic nerve will come through. If you want to get a little bit more complicated, or for complex disease, then we have a second model that will explain a certain kind of pathology, something we call a Sternberg canal defect, or these are patients who have spontaneous CSF leak or cerebrospinal fluid leaks from a lateral aspect of a well-pneumatized sphenoid sinus. This is really difficult to understand because if you use a normal model and you go through this greater wing of the sphenoid, you enter the middle cranial fossa. But here in this specimen that's according to real DICOM images, you can see in the purple or red discoloration here, the sphenoid sinus. So we can see how the sphenoid has become aerated, and so well aerated, it extends so lateral that it actually pneumatizes the greater wing of the sphenoid. So in this patient, where we would normally use a transnasal method, often from the opposite nose to get to that area, it's very destructive for the nasal cavity. You have to do a posterior septectomy, enter the sinuses. Often those patients have a palatal numbness because you damage the Vidian nerve. And also you damage the sphenopalatine artery, and you have to use a contralateral flap. So with the transorbital approach now, you can really understand and see how easy and quick it is if you dissect and you just drill away the posterior aspect of the greater wing of the sphenoid. You're going to enter that space, and it is super easy to fix it. So it really helps us understand this pathology. So once you've explained this to people, and you can use all the different approaches, one again for the anterior cranial fossa, you can use the orbit to access the CSF leak in the anterior cranial fossa of the cribriform plate area. You can access this in maxillofacial surgery for fractures of the orbital floor, where you might have a little crack and you have the inferior rectus muscle herniating through that area into the maxillary sinus. And you can explain to people how you would repair that defect now by plating it or putting a little bit of cartilage in there. So the next model up on that becomes a little bit more complex with more detail, and here you can see we have got the eye simulated with all the different muscles. We've got the medial rectus, we've got the lateral rectus, we've got the inferior rectus, we've got the superior rectus, we've got the inferior oblique, and beautifully demonstrated where the inferior oblique inserts, as we see the superior oblique insert at the level of the trochlea. And that's really important for people to understand, that when we look at the medial corridor, we work between the trochlea and we work between this kind of area at the bottom where your inferior oblique kind of attaches. So there's no risk of really injuring structures if we remain in a subperiosteal plane, because even at the level of the trochlea, if we dissect the tissue off and we remain in the subperiosteal plane, we will dislocate the trochlea where it attaches to the periosteum, to the bone, and as long as you place that back into place and suture it, you will not have any damage to the superior oblique. So in this model, we will also demonstrate all the different arteries and nerves, the important one, where they run in relation to your rectus muscle, so that if you do intraconal surgery, to help you understand the anatomy a little bit better. So the next step then is to really go to real life surgery, where we have this model. Consists of the skin and the subcutaneous tissue, which is very lifelike, and it's similar to a real patient's skin and the real thickness that you would experience. And if I just turn this model around, you can see how amazingly it's got the periorbiter that contains all the muscles on the inside below the eyelid, as we've just seen. So if we take those structures off, we're going to find these structures, but in more detail. We'll have the muscles, we'll have the fat, we'll have the arteries, we'll have the nerves. And what we see at the back, if you look at this eye from the back, you can see all the different important structures. And this is the nitty-gritty of transorbital surgery for the neurosurgeon. Once we've breached the greater wing of the sphenoid and we access this space, we need to see the V1, the V2 and the V3. You have to see all of these structures. Here you can see the cavernous sinus, we can see the carotid artery, and we're going to aim to dissect this in real life situation. So if I put this model in, it kind of slip it in like this, and you can tighten it, and this allows you to now drill this model, operate on it, and practice your surgery. And we've got different models. Eventually we will have different pathologies. You'll have a Sternberg canal defect, you'll have a sphenoid wing meningioma, we can have Meckel's cave tumors, we can have a different kind of anatomy. Just want to show you what it looks like from behind. You can really see, you can see the dura simulated here. The cranial nerves, the carotid artery, the cavernous sinus, with cranial nerve 6 running in the cavernous sinus. You have 3 and 4 in the lateral wall, and then V1, V2, V3 we will find as we do the dissection.